pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the October 9, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately in our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, can you have a roll, please?
Yes. Director Eapen.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee. Present. Director Stewart.
Present. Moving on to oral communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? No? Cheryl, are there any written communications?
There are no written communications.
Thank you. Move on to the consent calendar. Consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove the agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No. Does any member of the public want to remove an agenda item from the consent calendar? No. May I have a motion to approve the consent calendar items A through C? Director Wallace.
Mr. President, I move that the Board of Directors approve the consent calendar items A through C.
Second. Roll.
Director Eapen.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee. Aye. Director Stewart.
Aye.
All right, we have two presentations this evening. We're going to start with Dr. Harsh Agarwal, and he's going to talk about our structural heart program, and in particular, a Watchman device. And I'm going to give a little bit of an introduction to Dr. Agarwal. He started at Washington Hospital in 2021 as part of a TAVR procedure team from UCSF. He quickly built relationships with our local cardiologists and began to help them manage their patients' structural heart disease and to perform procedures such as mitral clip and Watchman device insertions. He has served as the Associate Cardiology Fellowship Director at UCSF, as well as Assistant Professor in Structural Interventional Cardiology. He continued to practice interventional cardiology and structural heart at California Pacific Medical Center while he builds our structural heart program at Washington Hospital. Dr. Agarwal has recently joined the cardiology group at Washington Township Medical Foundation and has accepted the position of Medical Director of the Structural Heart Program at Washington Hospital.
Thank you, everyone. I really appreciate being here. Can you hear me?
All right. Yeah, we can hear you, but we just, I think we need to, we're just trying to see you, Dr. Agarwal.
Yes, right here. Can you, I'm just opening my microphone. Can you see me?
Okay, there we go.
There you are.
Okay, hi. Thank you so much for the kind introduction. I'm honored to be here and help our community in the hospital. We have a slide presentation if someone can share, please. I was told it was run from there.
Yes.
Yes.
Thank you. I'll be talking about our new program that we have started at Washington Hospital with the help of our teams. Multiple people have really helped out in getting this going. This is something called the Watchman program, or left atrial appendage closure program. And Linda Antes, who's our co-director, has really helped out along with Larry, Kim, everybody. Also, a big thank you to all the team to bring this to our community. We can go to the next slide, please. So just wanted to tell the room what we actually are doing. Watchman is a small device that helps prevent blood clots in atrial fibrillation, which is one of the very common heart rhythm disorders in folks generally above 65. The most common reason is hypertension, and the most risk is with atrial fibrillation, people have a very high incidence of strokes due to blood clots, and if that happens, that could be life-changing and devastating. And most of the patients with atrial fibrillation have to be on a blood thinner, such as Coumadin, Eliquis, and such blood thinners, which are pretty potent blood thinners, and they protect people from strokes. Unfortunately, blood thinners come with their own risks of bleeding, and people who are very active or people who fall can have internal bleedings, even spontaneously, sometimes from blood thinners. And hence, since this procedure was invented, it has been done by CT surgeons as a surgical procedure for the last 30 years. When they do open heart surgery like bypass, sometimes they ligate this appendage, but now we can do this in the cath lab using an X-ray and ultrasound under anesthesia. It takes about 45 minutes, and it's through the vein in the leg, and very easily done with all the equipment. The device comes in 5 different sizes, so we can size it to each different patient. And patient wakes up around an hour. We observe them for one night and send them home the next day. Next slide, please. So as I said, it's for patients with atrial fibrillation who are at increased risk of stroke. We do this in conjunction with their own cardiologist or neurologist or primary care doctor. This is a very patient-centered approach. Patient comes in, we talk to them about it, we give them all the alternatives. And, it's the patient and the family physician and the cardiologist who all decide. We actually have a document that we get the primary care or our cardiologist to sign, make sure that we have done all this, and patient understands that what are we doing, why are we doing this, because we have had a lot of patients who are pretty active with atrial fibrillation, who have fallen, hit their head, had bleeding issues. They cannot be safely on anticoagulations. That puts them at higher risk of stroke. And there are multiple clinical trials now that have come out that's showing more than 500,000 of these have been done in the world, and they are as on par with the blood thinners in terms of safety and stroke prevention, with the lower risk of bleeding. Next slide, please. As I said, there are multiple risk factors for stroke. Most common is the age, anyone above 75, atrial fibrillation, heart failure, a lot of hypertension and diabetes puts you at a risk of stroke, increased fall risk, bleeding events, vascular disease, or if patients, are unable or are unwilling to take anticoagulation just because of any reason, we still have an option to protect them from these devastating strokes if they happen due to atrial fibrillation. Next slide, please. So atrial fibrillation and stroke, as I was saying, it affects the heart's ability to pump, especially the left atrium, and that's where most of the clots form, about 90%. The issue is if they dislodge, generally they travel to the path of least resistance, is generally the brain or the kidneys. Atrial fibrillation strokes can be very life-changing, as I said, and debilitating. And all the studies have shown about 90% and above clots from in this area of the heart called the left atrial appendage. The Watchman device was made for this, to fit into this area of the heart called the left atrial appendage, and basically close it off from circulation, and the clots then don't form in that area. So that's how it works. It doesn't damage the heart or does anything different. It basically sits there and just prevents, like a stopcock, prevents the blood from flowing in that area of the heart. Next slide, please. Benefits, as I said, it's lifelong stroke reduction. We can stop the blood thinners in about a month.
It says a microphone array and CMS system.
Oh, sorry, someone's microphone is on. And then improve quality of life. As I said, no blood thinners and no more blood tests. Then Risks, obviously, the risk of anything bad happening has been put as 0.5 to less than 1%. We do it very safely. We plan this with the prior echocardiograms. And device dislodgement, infection, risk of anesthesia, or heart puncture in the sense that, from the device is, as I said, 0.5%. We have done more than 19 to 20 of these at Washington. I've done a bunch of them at UCSF. It's very, very safe. It's the third generation device now that they have. It has a skirt around it, and the tines that come with it are very, like I felt it in my hand, and I try to tell the patients to feel it too. We have a device model, and it's much more safer than the first generation device, the third generation Watchman Flex. Next slide, please. So this is the timeline. I just wanted to show everybody that, this started off in 2002 as the first procedure in clinical trials. It was approved by the FDA in 2015. And then the FDA, the third generation device that we are using currently, was approved by the FDA in 2020. They have about 500,000 20 years of clinical trial data. And about 300,000 Watchmen, but 500,000 left atrial appendage occluders have been inserted. As I said, success rate is above 99, I would say like 95 and above percentage, 5.5% risk of anything bad happening. And if it works well, we have 100% closure. And about 95 and above percentage patients are able to stop their blood thinners, which is very, very good. If you look at blood thinner data itself, they have a bleeding event rate of 2 to 3% per year in elderly population, so which is very significant if you think about it. Next slide, please. And as I said, it's basically this big device. It's very small. I know it looks big on the screen just because we have to sort of enlarge it, but it's literally a size of that coin that you see right there. They have multiple sizes. Actually, they introduced a 40 millimeter size too. Now there are 6 of them that can basically conform to any anatomy, body size. So that's why the success rate is so high with multiple sizes for each different, because everybody is different. Even insides of everybody's heart is unique. Next slide, please. And and now we are listed as an implanting center and a center for atrial fibrillation in the Bay Area. As you can see, that little star is us in Fremont. They have about 10 to 12 programs, but in this Tri-City area, we are the only program offering this device now. Next slide, please. And this is our registry from Washington Hospital. Our success rate was 94%. The reason is that is one patient had a clot, so we had to abort. No major complications. We've done very well, and our performance rate meets the FDA indications as 100%. Patients are a very high risk of stroke. As you see this CHADS-VAS score, that's a predictor of how high your stroke risks are. Our patient, we can go up all the way up to 10 almost on this score. Our patients are average of 6, which is pretty high if you compare it to the national average. And the HAS-BLED score is something about, we calculate how much bleeding risk do they have on blood thinners. And it goes from till 5, and our patients are average of 3, which is also pretty high. So we have a higher risk population in this area where we can offer this procedure now. Next slide, please. Questions? I just want to say thank you everybody again who has helped out this program. It's taken, a lot of work for us to make it work, but I am glad to say patients are, inquisitive. We are having patients come see us. Recently, there was a patient who was supposed to see someone at Stanford, but they decided to come see us and get their procedure done at Washington Hospital. Same thing. No one wants to, they were used to go to the UCSF for such procedures. I used to take them, but now we can do them here. So very, very exciting times for us. Thank you.
Thank you.
Thank you. Thank you, Dr. Agawam.
Any questions for Dr. Agarwal?
Thank you, Ash. Great presentation. The only thing I wanted to ask you was, is there a shelf life on this product? I mean,
Not really, sir. We have the first one was implanted in Europe in the late 1990s, and they've done TEs and CT scans. Once 6 months out, they endothelialize. We have patients who have done it in 2005. They're still going on. So once it endothelializes, the risk of clot forming on the device or anything bad happening is basically 0%.
good. Thank you.
Yeah.
Thank you.
All right.
All right. Thanks.
Thank you,
very
everyone.
much.
Thank you.
Want me to move on? We have a second presentation this evening. I'm very pleased I will introduce Angus Cochran, our Chief of Community Support Services, and a fun presentation that I think all of us really enjoy every year, and that's our participation in the Alameda County Fair and the Junior Livestock Auction. But before I do that, I will introduce Angus, and then I know he has a few introductions to do also. So Angus Cochran has been with Washington Hospital Healthcare System since 2006 and is currently serves as our Chief of Community Support Services. In this role, he is the liaison to the Service League and manages community outreach and the Health Insurance Information Service. He's also responsible for governmental affairs for the healthcare system. Angus earned a bachelor's degree from UCLA and a doctorate from Columbia University. And Angus, I'm going to pass it over to you to introduce our other guests.
Well, thank you, Kimberly. I appreciate that introduction, and good evening to the members of the board. It's great to see you. We will not be presenting anything quite as technical as Dr. Agrawal, but I'm happy to report that an aunt of my wife's just got implanted with a Watchman about 6 months ago, and she's doing great. So our family we're 2 thumbs up for the Watchman. So this evening we're here to talk about the Alameda County Livestock Auction. I'm joined this evening by Addie Hoffman, if you want to wave, Addie, if you're out there, and Rowan Bachelder, and Lily Stern. So thank you all for joining us. Shui, if you could share our slide deck too, that'd be terrific. Great. Maybe we can go to the next slide. So I'm here to introduce the program again and our work that we do with the Alameda County Livestock Junior Livestock Auction. We have the presenters will be here, and we'll have some questions and answers if you'd like. First of all, I just have to give out some thanks to a couple of my colleagues, Mary Boren, Chief of Quality and Resource Management, and Matthew Shimana, who you can see in the right-hand picture here. Mary and Matthew spent the days with me at the livestock auction. We also went for a whole day ahead of time and interviewed all the students and met their animals. And we also paid a visit to the Ardenwood Farm in North Fremont, where our local 4-H club, the Bayside 4-H club, keeps their animals. That was great. We'd never really met the animals in their home environment before, and so it was good to see them very relaxed in their pens and in stables. I really also want to thank Kimberly Hartz, our CEO, she spent the whole day of the auction with me and was very helpful with the bidding. We might have come home with a couple of extra piggies as a result, but it's great to have you there, Kimberly. Really appreciated your support. Next slide, please. So, we are generally every year we are the #1 bidder at the auction. We spend a fair amount of money to buy this wonderful livestock. It's a full day auction with chickens and rabbits and turkeys and goats and lambs and hogs and steers. We tend to steer clear of the rabbits and turkeys and chickens, but we focus on the lambs and the hogs and steers. This really began as a project with County Supervisor Scott Haggerty, and I'm happy to say we've carried on the tradition by partnering with Supervisor David Haubert in recent years as well. The animals are raised all over Alameda County, mostly in the Tri-City area and also in the Tri-Valley area as well. And this is a picture of Jeremiah Cullens and his beautiful hog, who we we were invited into our cafeteria a few weeks ago.
I was wondering, I was going to say that.
Yeah, got to be careful with these things. Next slide, please.
Maybe on the
So the question is, why is the district hospital taking part in the junior livestock auction? I think most importantly, it's a way that we can invest in the community and invest in youth development. It helps, as you'll hear from our guests today, it really helps with their business skills development, and it fosters skill sets that can be translated into the workforce of the future. And we want to make sure that we are relevant and present in the community. A lot of our employees, surprisingly, have either children or relatives who raise livestock as well, and it's a way for us to help them and support them. Obviously, there's a lot of character development involved in raising livestock, and I think from a larger perspective, it allows us to try and keep agriculture in our district, which is part of our tradition as well. Next slide. So the primary way, as I said, that we support the event is by purchasing livestock. This year we bought 15 hogs, 4 lambs, and portions of 2 steers with Supervisor Halbert. The meat, people are surprised. They wonder, what are we doing with the meat? And we serve it in the cafeteria. We serve it to the Rotary clubs. We take it for the patients in their rooms as well, and in the cafeteria too. And we have a wonderful partnership with Food and Nutrition Services, who love this high quality meat and make some really delicious lunches and dinners with it as well. Many of the animals that we bid on are raised in the district with the Bayside 4-H Club. And then we also, and unfortunately, that club meets on a Wednesday evening, so they could not join us this evening. But we also buy animals from 4-H clubs in the Tri-Valley area and from the last Future Farmers of America program at Livermore High as well. We have amazing name recognition in the Tri-Valley agricultural community as a result of this. And many, I frequently hear stories of people coming over through snow for care. And it really, I think it helps our brand over there in Tri-Valley area too. Now, I think we're going to move on now to some presentations. So Lily, are you out there? Would you like to begin your presentation? I don't see your face here, but
hello.
There you are. Hi, Lily.
Hi. Well, clearly, my name is Lily Stern. I'm not sure if my slides are out there.
Coming there. We bought Lily's market hog, and if we can go to the next slide, Shri.
Yes. So, hi, I'm Lily Stern. I've been a member of 4-H since I was 8 years old, and I recently graduated from Castro High School in the spring of 2023, and I'm currently going to school at Las Positas College. I started small. There's a couple pictures on there of me holding a chicken or doing some sort of presentation. I was doing chickens and nearly any other project I could because I couldn't do large animals yet. And my passion for animals and educating others about them just kind of grew from there, leading to pigs, steer, and valuable life skills. But I don't think 8-year-old me would have cared as much about the life skills compared to the chicken, but I digress. And of course, aside from 4-H, I love being outside and trying new foods and stuff like that. If I could get the next slide, please. So this past year was my year out, and I raised a market steer named Cash in a market pig in June. I decided to go with the Johnny Cash theme. And I chose Cash because my steer loved to sing this year. He was a talker. And swine projects last around 4 to 5 months, while steer projects last closer to 10 to 11 months. So we are putting a lot of time into these projects. And within that, there's a lot of care that goes with it. And it's important to keep up with grooming and bathing your animals for steer. You make sure that their hair is good, all in the right direction. Make sure their skin is healthy, no lice, stuff like that. Just normal health things, keeping up with your animal. And for pigs, it's more so conditioning. Another really crucial part is showmanship, working with your animal, putting the time in. You're going to get the time that you put in with your animal. Enrichment is also a very important part, in my opinion. My steer this year loved playing soccer, as you can see with his ball up there. And fair prep, you clip your animals before show, just get them looking their best. as you can see in that photo on the bottom right, I was on crutches. I actually broke my leg during this year of showing, so that was definitely a challenge. And it was definitely bittersweet because it was my last year. But I am so incredibly proud and happy that I was able to be back on my feet around February and really able to work with my steer and do all the things that I really wanted to do for my last year. Next slide, please. So here's the cost breakdown portion, which I know is Matthew's favorite. And so what I like to do is I personally make a spreadsheet and I track my expenses. And as you can see, I divide them between one-time expenses and recurring expenses. My total expenses for steer this year was $8,895.16. It's a very expensive and time-consuming project, which is why they're a little expensive, I would say. But these expenses include feed, which I would say is the biggest expense. And one thing that's really important to me as a producer of these products is that I ensure that all the products that I put in within my animal, I would be okay with eating by myself. I would put those things in my body, and that's really important to me. So Cash weighed in at 1,500 pounds at fair check-in, and buyers only pay up to 1,300 pounds. So to find the break-even, I would divide my $8,895.16 by that 1,300 to get a break-even price of $6.84 a pound. And then on the next slide, I go over my pig breakdown, and it's a lot of the same thing. June weighed in at 259 pounds this year at fair. So to find a break even, the overall cost for pig is significantly less. It's a shorter project. They're usually less expensive. And my total was $2,521.54 in expenses. And I divided that by the 259 pound weight, bringing me to $9.74 a pound. And then on that last slide, I go over fair and auction, which is what a lot of this presentation is about. This year, I had an amazing time to end as an exhibitor. Cash and June did amazing, especially with how hot it was. I'm very proud of how we did. We had a couple hot ones out there, and I had a great time with friends. I was asked to come back as both a community club leader as well as an assistant steer leader for my club, the Valley Vista Club. And that's something I was so honored to receive. So I was also able to kind of start leading and start getting my foot in the door of transitioning from an exhibitor to someone that just helps everyone else do their thing. Auction, of course, is always a very bittersweet day. I spend a lot of time with these animals, so it pulls at my heartstrings. But I always like to remember that I guaranteed that I gave these animals the absolute best life I could possibly give them. And I'm proud of the product I produced and the life I gave them. And every dollar from 4-H I've ever made, I've ensured that I put into college. So I just started using it now. So it's very valuable what 4-H has given me in the time I've done. So I would like to thank you for supporting me. Obviously, you purchased my pig this past fair, and I truly appreciate it. Thank you so much.
Thank you so much, Lily. I think you were so good at keeping in touch with me during the year this year and sending me pictures of June and Cash that were up on my pin board all year long. And for me, what you really showed was how it can be an activity that a student can do all the way through high school. And as you grow, you learn new things and apparently get larger and larger animals as well. So congratulations, and thank you for coming and presenting this evening.
Thank you so much.
Can I have the next slide, please? All right, our next presenter was here last year, and he's like a good penny. He's back again. This is Rowan Batchelder. We placed the winning bid on his 119-pound market lamb, and he's a member of Redwood 4-H Club. Take it away, Rowan.
All right, thank you. Hello, my name is Rowan Batchelder, and I'm in 7th grade. I go to Creekside Middle School, like Lily's brother, by the way. I love math, history, and playing my trombone. I recently made a competitive soccer team this year, so I'm enjoying playing goalkeeper for that team. I love playing D&D with my friends, and I'm one of 2 kids, Zach, that does 4-H at my school. Raising a sheep, it takes a lot of steps. Step 1 is you have to pick your lamb. Choosing a lamb takes a lot of insight. Things to look for are square hind legs and a straight back. But you want to make sure that the legs are in line with the butt, the feet are square, and your back to be straight, perfectly straight. Once you choose your lambs, you have to feed them regularly. Our project, we take turns feeding because we all raise sheep at the same ranch. You have to also walk and exercise them, and being at a ranch is also super helpful because it happens to be right next to a hiking trail. So we just walk our lambs up and down the hiking trail all the time. And you also need to train it for showmanship and to like be able to brace well and to walk. Finally, when it's time to go to fair, you load all the animals in your project into the trailer, and then you go to fair. Next slide, please. At fair, you show each of your lambs for market, and then you pick one for showmanship. The market show is where the judge is judging the quality of your animal. So this is where the straight back and the square butt come in, because that will give you a lot of points on the judging. And showmanship is where you are judged on how you handle your lamb. You can see me in a picture showing the judge. And then there was also not a show, but it's a competition between all of the projects in your animal group. So we would be competing with Valley Vista sheep and Crane Ridge sheep and like all the other sheep projects from different 4-H clubs on herdsmanship, where we actually won it, and this year we got a big banner for it, and you gotta make sure the condition of your pens are like super good. So you want we had sprinklers because it was so hot this fair, and so not gonna lie, we did have some water guns, and we just sprayed over the pens a lot at each other. So that's what we did, and this year's auction was pretty much the same as last year's, but I didn't have a super fat lamb this year, so that was really good. I did break even on both lambs, and I'm really happy about that, because I was a little bit worried because they weren't underweight, but they had a lower weight than the average. So let's see. I needed at least $6 on each lamb because their weight was so low to break even. So I got $11 a pound and $10 a pound on my lambs. So I got in total, putting in all the expenses, I got a total of about $1,200 this year. Profit. My lambs did not gain much weight this year. I think mostly because they were in the sun with little shade. We were on the top of the hill, and there weren't many trees, unfortunately, because of the flooding the year before was so bad. And so they didn't eat because they were too hot, and I think they had a lot of water weight on them too. I practiced a lot with my animals this year, so I was really good. And I did a lot better in the show ring, though the judge was, so overall, this was one of my best years so far. And thank you, Washington Hospital and Mr. Cochran, for supporting my land project.
Very good.
No, it was a pleasure, Rowan. I mean, I don't know. I know that your lambs weren't quite as heavy as last year, but last year you were having trouble wrangling them, and this year they completely were under your control. So I think it's not just their weight, but I think you're bulking up and growing up as well, and you had complete control of those lambs. So Rowan, thank you for joining us this evening, and we hope to see you again next year.
Yeah, thank you for inviting me.
You're most welcome. And our final presenter this evening is Adeline, or Addie Hoffman. We were part of the group that had the winning bid on Adeline's 1,378-pound Reserve Supreme Champion steer. And she's a member of Sunol 4-H Club. And Addie, if you want to present your slides now, that'd be great.
Yes, thank you.
And we can't actually see you, Addie.
Is it better now?
Yep, there we go.
Hey.
Perfect. Next slide, please, Shri.
So hi, my name is Addie Hoffman. I've been in Sunol 4-H for 11 years and counting. This will be my first year of high school as well. It'll also be my first year as a Future Farmer of America member at the Livermore High School. In FFA, I'm learning to judge the quality of livestock and compete in competitions with my team. This year, I'll be raising a lamb for the first time and also compete in public speaking competitions. Next slide, please. Raising livestock is truly a wonderful part of my life. It takes a lot of responsibility and patience to raise a variety of livestock. As hectic as it can be, it is rewarding at the same time. Knowing I am raising quality market meat for the sale at the Alameda County Fair Livestock Junior Auction. Next slide, please. There are lots of challenges with raising livestock, having the space, having the responsibility, the time, and patience for it all, and to adapt for the occasional emergencies. Unfortunately, I do not live on the same property as my animals, but I am so blessed to have very close friends to let us use a large part of their land. I've learned so much from raising livestock, and I wouldn't know where I would be without it. Raising livestock has made me responsible, understanding, and hardworking. Next slide, please. As more years pass by while being in the ag industry, I've come to learn that these will be the best years of my life. I've made many friends in the last 11 years, and I couldn't be any happier. Being an ag kid has taught me what hard work really is, and that there's always going to be bumps in the road no matter what you're involved in. But you have to just keep working through it because the hard work really pays off in the long run. Next slide, please. Last but definitely not least, I would like to thank the amazing staff that you employ at Washington Hospital. My Uncle Jack had a brain aneurysm rupture 19 days before I was set to enter into the fair, and it was a touch and go and very stressful for all of us. Thankfully, he has made a full recovery. He's well and alive because of your amazing staff. Thank you for being such an amazing support to the youth at the Alameda County Junior Livestock Auction. We couldn't do it without your support. Thank you.
Oh, thank you, Addie. Can you tell us what it means, what Reserve Supreme Champion steer means?
So Reserve Champion means that instead of winning first, you're second out of the whole fair. And last year I was Supreme Champion, but this year I took Reserve.
But that's still a pretty good result, and it was such a beautiful steer that you had in the auction.
That steer also was super steer. So he had the best carcass out of all of the steers at the fair this year.
Great.
Wow.
Well, we're looking forward to great things. And good luck in high school and good luck at FFA. And we'll hopefully see you again at the auction next year.
All right. Thank you.
Thank you. And this is our final slide. It's really just a thank you to the board, to thank you for continuing to allow us to invest in this great program. The kids are so enthusiastic, and so hard working with their animals. It's very infectious. And we have a long tradition of agriculture even here in the Tri-City area. And I think it's really worthwhile to have these open spaces devoted to raising animals. And thank you to the board and to Kimberly for supporting this tradition. We love taking part in it. We're happy to answer any questions.
Does the board have any questions for this amazing group of speakers?
Yeah.
Keep at it.
Yeah.
Thank you.
Thank you so much, and thank
Thank
you
you all.
for sharing your experiences. It's wonderful to be able to see from the very beginning and how it comes to where we see it at the auction. So thank you for sharing.
Keep up the hard work.
Yes.
Thank you.
Thank you.
Thank you.
Get on in there and get you a drink.
I think I will.
Oh, no, John, I got different cards.
Oh, okay. I'll sign it.
Okay.
All right. Thank you, Angus. We appreciate you and putting everything together. So thank you for all the hard work you do.
Thanks,
It's one of my favorite parts of my job, I have to say, and it was great having you there to help us work within our budget.
Now I'm not the best person to brag. I will keep wanting to bid it. So,
Keep at it.
yeah.
Variance comment.
Good night.
Good night.
Right. On reports.
Right, we're going to move on, and we'll start with Dr. Saleh for the medical staff report.
Hi, good evening, everybody.
Hello.
Those are hard acts to follow, as always. These presentations are always so good. Dr. Agrawal and these amazing kids and Angus, wonderful things to hear. Mine is not as exciting. So I'll start with the medical staff census. We have a grand total of 658 members. A little more than half, about 347, are active. The remainder are spread out among administrative, advanced practice providers, ambulatory, consulting, courtesy, one leave of absence, 100 who are provisional active and being credentialed, and the rest are provisional, advanced practice providers, consulting, and with temporary privileges. For the Chief of Staff report, we had our medical staff luncheon on September 27th, about a couple of Fridays ago. That went really well and was well attended. It was really nice to meet some old friends and some new members who got to know everybody else. We also have the Top Hat this weekend, of course, to raise money for the MRI. That's on Saturday, October 12th. That a lot of people are looking forward to and should be a wonderful event. I think that is about it, really, from my standpoint, unless anybody has any questions.
No, thanks, Mark. Thank you.
Thank you.
Thank you.
My pleasure.
Moving on to Sheila Vijay, our president of our service league.
All right. Good evening, members of the district board. Again, warm greetings from all the volunteers. Here's my September report. I'm pleased to report that in September, our volunteers contributed a significant number of hours across various departments. 226 Service League volunteers dedicated a total of 1,943 hours to the hospital. The Director of Volunteer Services, Evangeline Imana Iamura, and I attended the California Association of Hospitals and Health Systems meeting. This is actually a volunteer leadership meeting on September 14th and 15th in San Diego. It was very informative and provided a wealth of ideas to improve our services. Additionally, we participated in a panel discussion focused on the reopening and success of our gift shop post-COVID-19 pandemic. We discussed strategies and challenges we faced, and I was a little surprised to learn that some hospitals have not yet reopened their gift shops since the pandemic. I believe either the volunteers did not come back or they just couldn't open it back up. Saturday, September 28th, the New Haven School Foundation hosted the Mud Strut, their annual fundraiser. All pet lovers and their four-legged friends were invited to join. This event has been supported by Washington Hospital for many, many years. The Service League participated to help promote our Wolf Dog Therapy volunteer program. Ember, our Wolf Therapy dog, joined in the fun along with her handler, Teresa Peters. Ember, our wolf therapy dog, proudly won both the hot dog eating contest and best dressed competition. She was very good at strutting and showing her, how good looking she was. It was a great day to connect with the community and celebrate our team spirit, and hopefully we'll be recruiting additional wolf teams. We are still exploring ways to better engage our high school volunteers, including the possibility of opening the gift shop in the evenings starting in November from 4:30 to 7:30 p.m. all 7 days a week to increase overall opportunities for the volunteers. That's the end of my presentation. Please let me know if you have any questions.
Always good to see you, Sheila.
Thank you, Dr. Stewart.
Looking forward to Top Hat.
I will see you there for sure.
Thank you, Sheila.
Thank you, sir.
All right. Yeah. Next, we have Dr. Diane Martin, and she is going to give our annual respiratory season update this evening. And just a little bit of background, I know Dr. Martin is very familiar to many of us, and she has worked at Washington Hospital and been part of our medical staff from 1984 to 2023. She has also served, of course, in many leadership roles. Since she retired from the Washington Township Medical Foundation in 2023, Dr. Martin has continued her role as the Washington Infectious Disease Program Consultant. She's also currently the chairperson of the Antimicrobial Stewardship Committee, as well as the chairperson for the Infection Prevention Committee. And she serves as one of our key leaders during the peak of the COVID response planning and continues to do so today. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine. Welcome, Dr. Martin.
Thank you very much. I'm pleased to present our update for the respiratory season, which we made some modifications to try to include additional information for this respiratory season year. Next slide. So we are still anticipating co-circulation of influenza as well as COVID-19 and respiratory syncytial virus. The updated vaccine remains the primary strategy to reduce severity. Vaccines are not 100% effective, but they do reduce infection when it's present and also reduces spread of infection to other people who might not be vaccinated or are more vulnerable. So updates to the vaccines currently include the influenza, which has got 3 strains in it compared to the usual 4. 2 are influenza A, one of which is new, the H3N2, and also influenza B, which is the Victoria. This composes the current season, and we feel that it's going to be very effective. COVID-19 covers the current variant, which is the Omicron, and these are changes from last year's vaccine. The RSV vaccine does not usually change, and from year to year, this one has been relatively stable. Vaccines are almost always covered by all the insurances, but you need to verify with your provider, whether it's the pharmacy or the physician, to make sure. I also want to stress it's never too late to get the influenza vaccine and the other vaccines. So we want to encourage people to get it at the beginning of the season, but if something interferes and you need to have resources available to you, it's never too late. Next slide. As a little bit of background to go over the flu, COVID, and RSV, flu is mostly seasonal, and it's caused by influenza A and B, which does peak in the colder months, which is why this is the prime time now to get your flu shot, so that your system has the immunity prepared for when the flu season does peak up. The COVID-19 is caused by a coronavirus that continues to evolve because we are now seeing the Omicron variants, and the new ones do cover that. Impact remains very significant, especially for high-risk populations, because we see in people who are more vulnerable, have emphysema, heart disease, diabetes, cancer treatments, they're very high risk for complications. Respiratory syncytial virus is another one that causes an illness very similar to an upper respiratory or cold infection, but it's very severe for babies, infants less than 6 months old, and older adults who can become quite sick from RSV and need to be hospitalized. All three viruses have varying degrees of sign and symptoms, and people can be infected and have no symptoms at all to very severe symptoms needing hospitalization. The most common symptoms that we see include fever, chills, cough, may be productive or not, shortness of breath or difficulty breathing, fatigue, sore throat, runny nose, body aches, headache. Some people do get vomiting and diarrhea, but that's much more common in children than in adults. Next slide. So to go over how these viruses are spread, next slide. Shri, can you advance the slide? There, thank you. Okay. They're spread mostly by transmission, mainly by droplets such as coughing, sneezing, talking. If you've ever seen that very famous picture where a person is coughing and it's backlit, you can see all those droplets flying through the air. And that's how these viruses then transmit from person to person. So breathing, speaking, singing, exercise, all of those do cause spread of the virus. There's direct contact with surfaces that have been infected or objects that get infected when somebody is sneezing or coughing into their hand and then touching another surface or object after touching their eyes or nose. It can also be spread by people before they begin to show symptoms. So you can be infectious and therefore contagious even if you have no symptoms or very, very mild symptoms, and some people never develop any symptoms at all. Complications are much varied. So people can get secondary bacterial infections on top of the virus infection, pneumonia, sepsis, which is bloodstream borne, respiratory failure, such that they might even need to be on a ventilator, neuromuscular complications where they get very weak, have reduced stability, lung complications such as being congested, heart complications, we see what's called myocarditis, which is inflammation of the heart lining, which is very typical with these viruses. Many times patients need to be hospitalized, and there is mortality, sometimes death from these. Next slide. So what are our defenses? Vaccines. And again, never too late to get your vaccine. We always encourage people not to put it off, but if it's not the right time for you and you need to think about it, do it, but certainly follow through. The vaccines stimulate antibodies which protect us against the viral infections. And research shows that the most common are upcoming respiratory season. The flu vaccine was updated, as I talked earlier, 3 strains. It's available as a standard dose, which is bred in egg cells. There's also a high dose for elderly or people immunocompromised. And this year there's also an egg-free vaccine because we have seen some people who have egg allergies get a reaction to an egg-based vaccine. The COVID-19 has been updated, like I said, to include the Omicron. There are 3 vaccines available for COVID-19. 2 of them are what we call mRNA, which is messenger RNA, which basically triggers the body to make antibody to what's called the S protein or the spike protein, and that conveys immunity. That's provided by Pfizer and Moderna. Then there's also what's called the Novavax, which is more of a traditional virus blocking technology, such as we would see in measles vaccines or flu vaccines. But again, what it's triggering is antibody to that spike or S protein. Respiratory syncytial virus vaccine has different types of vaccine, Pfizer, Moderna, and GlaxoSmith. All of these are equally effective, but many pharmacies only carry one of the actual options. Next slide. So people want to know, how often should I get a vaccine? And it varies. The flu vaccine is annual. Everyone over 6 months or older, especially what we call high risk, which are elderly, pregnant, immunocompromised, such as diabetes, people going through cancer treatments, and those should be prioritized to get vaccine. There are also high risk individuals who have life-threatening allergies to flu or what's called Guillain-Barré, who probably should not get egg-based vaccines. There are those that are available which are non-egg-based, which should be considered. Influenza vaccine has updated, and we've already started at Washington Hospital our blitz to vaccinate staff employees. COVID-19 vaccine is annual for everybody 6 months and older. The Pfizer and Moderna are available for all ages, and the Novavax, which is the one that's a little more differently produced, is for 12 years and older. People who are moderately or severely immunocompromised should probably get a second dose. So if I'm getting my COVID vaccine at the end of September, then I probably want, and I fall into this category, then I want to get a booster in about 2 months after this vaccine. So over the years, we've gotten COVID-19 vaccines every year, but this would be a 2-month booster for those whose immune systems are compromised. The respiratory syncytial vaccine is somewhat different. It's for adults 60 and older with high-risk conditions, all other adults 75 and older. It's also recommended for infants in what we call the RSV vaccine season, which is September through January. And again, we recommend it in pregnant women whose children may be delivered within the RSV vaccine season, because the vaccine in a pregnant woman conveys antibodies to the unborn child. So when the child is born, it has antibodies already. The RSV vaccine is a little more unique in that if you had the RSV vaccine last year, you don't need one this year. The FDA is still trying to determine what the sequence should be in terms of vaccinating for RSV. Next slide. So what is Washington Hospital doing? Washington Hospital has implemented many measures to reduce the transmission of respiratory illness. As of November 1, we mandated universal masking to all inpatient areas in the main hospital building, which includes Morris Hyman and the emergency department, the perioperative services, high-risk areas such as the infusion center, the UCSF Washington Cancer Center, Radiation Oncology Center, our pediatric unit, and most of this has been strongly encouraged by Alameda County Public Health. We encourage people to do self-screening of symptoms prior to coming to the facility, such that if you're ill with anything that you think might be related to any of these viruses, probably should either do checks at home, contact your physician, but probably not come to the hospital. We do immediately isolate any patients that are coming in that are symptomatic. All surgical patients that are symptomatic or compromised patients, regardless of symptoms, will do mandatory COVID testing. Masking is optional for patients, visitors, workers not in clinical procedure areas such as lab or x-ray. Next slide. So these are some of the frequently asked questions. Does the flu virus work? So it does, but it's about not 100% effective, but it does give most people a 40 to 60% lower chance of getting seriously ill than an unvaccinated person. People ask the question, do I need a flu shot and a COVID vaccine every year? And the answer is yes. Most of these are vaccines that are changing from year to year. So vaccine protection does waver, decrease over time, but it's also important to update against the current COVID, like the Omicron, or to the influenza vaccine for the strains that we're currently seeing. People want to know if I can get the flu, RSV, and flu shot and pneumonia shots all at the same time. So the answer is yes, but you may want to talk to your healthcare provider ahead of time just to make sure that it's safe for you. You also want to get them in different sites. So the other question is, when do I get the vaccine? We recommend that you get them at least by the end of October for the flu and the COVID. The RSV is effective year-round. And again, never too late to get the vaccine. Next slide. So these are some of the frequently asked questions. Will the updated COVID vaccine protect me? So it's not 100% protective, but it does protect against severe illness, hospitalization, and death. And the updated vaccine will protect based on what you have gotten from the vaccines in the past. So if you had one last year, the immunity builds on what's already been seen by your system to build up protection. Occasionally we see people who don't feel well after the flu shot, and that's not unusual. The symptoms should be fairly mild, but they are very flu-like in the terms of sinus congestion, feeling weak, low-grade fever, and there's also soreness at the injection site. But this tells you that your body is making protective immunity to fight the flu in the future. Occasionally, we see people who get some of these symptoms lasting 1 to 2 days, but usually it's only a few hours. And the symptoms are much less severe than an actual flu illness. The other question people ask is, can the vaccine give you the flu? And the answer is no, because there's no live virus in the flu shot. There's 2 flu shots. One is inactivated virus, and the other one is the recombinant, which is basically what we call cell-based, and it's not egg-based, and it's what's called flu block. And this is very similar, again, to the hepatitis or shingles vaccine. Next slide. So people want to know, what can I do? Answer is, get your vaccine. So get the COVID-19, get your flu shot every year. And if your physician or healthcare provider recommends the RSV vaccine, go ahead and get that one. The other thing that'll never go out of style is good hand and personal hygiene. Wash your hands before you eat, before you touch anything else, before you go shopping, after you get back. So more is better. If you're sneezing, cover your mouth if possible. Either cough into your sleeve, elbow, rather than your hand, but go ahead and wash your hands regularly. Social distancing helps. So if you're in a crowd and you're feeling a bit weak or tired, or you're concerned about getting too close, social distancing always helps. If you're also worried about your immune system, your heart patient, diabetes patient, you can always wear a mask in high-risk areas. Again, don't delay care. Don't worry that this might be something not as serious. If you have underlying conditions, contact your healthcare provider. Many of them do tele and video visits so that you don't always have to come into the office, because they also want to make sure that if you have something more serious, that you're not going to spread it to the people in the offices. Next slide. This is my last slide. How can you get a vaccine? You can get the COVID vaccine at most of the local pharmacies, including Costco, Howlers. There's also COVID test kits. The government's now providing these again for free. I'm suspecting it's going to be pretty limited, so I sent mine in and I got mine last week. But if you go to www.covidtest.gov, they will send you, I think, 4 test kits. So where can you get the flu vaccine? Your primary care provider can provide this, or local pharmacy. RSV vaccine, please talk to your healthcare provider and see if this is appropriate for you. Most of these vaccines are available at the doctor's offices and pharmacies, including CVS, Walgreens, and Costco. So that concludes my presentation. I'll be happy to ask questions, and thank you for letting me present this as a community service and letting people know what we're doing at Washington Hospital to protect them going forward.
Thank you.
Thank you, Dr. Any questions?
Yeah, Zain, 2 questions. One, the response rate of flu vaccine is always, troublesome. This year, the flu season, I think in Latin America or South America, it's pretty much done. And the reports that are coming out of this year's response is, I think, not very good.
Well, it's one of those things that we always worry about. I mean, they try to predict the response is and the tailoring of the vaccines so far in advance, 6 to 8 months it takes to produce these. So I would still encourage people to get the flu vaccine. It does give you some immunity, and there's really, if you're not having egg allergies, there's really no downside risk.
The other question I had was, the state has got certain vaccines for school entry, it's mandated. But somehow, I think the flu vaccine is not on the list of vaccines that are mandated. And, as you know, most of the spread happens in schools and kindergartens and preschools. There may be an opportunity for someone to support a bill to make flu vaccine, or maybe Washington Hospital can take the initiative, and if it passes, I think it'll be a great marketing tool for Washington Hospital. I don't know why that doesn't happen, but they even have hepatitis A mandated for school entry. why not flu? You know?
That's something that, because you're working with children more than I do, I don't think I know why it's not mandated. I mean, we certainly strongly encourage people to get flu vaccine. I know Washington Hospital encourages all of their staff to get flu vaccine. And if they decline, which is their right, then they have to wear masks for the entire November to, I think it's April. So I don't know that we can encourage children, schools to adopt that, but I don't know if you know principals or different, health within the
it has to be a state. It has to be a state law. I mean, it cannot be a school district wise. It has to be.
Okay.
All right. Thank you.
Thank you.
Diane, I have a question.
Okay.
We all run into patients who are vaccine reluctant. And I'm talking about patients who have been reluctant to get a flu vaccine for many, many years. And this is even prior to the issues that we have with COVID vaccine uptake. Do you have any magic words that you can tell these patients that can convince them? I struggle with this every time I see somebody who says, I never get a flu vaccine, or I got it once and I got sick and I'm never getting it again.
So, I mean, that's super good question. And actually, the term for that is vaccine hesitancy. They actually have a term for that now. So basically what we want to do is you're going to need to set aside more time for that person and sort of explore with them what's holding them back. I mean, why is this so scary for them? And try to see if you can explore that, or try to see, where it is that maybe there was somebody else who got sick in their family, or something else that happened, or they had a very severe reaction. But it requires a lot of time to sit down and, without judgment, talking to that person one-on-one and listening to what they have to say. Sometimes what we have done, and it's probably off-label, but we've done it with the flu vaccine, is to give them a half dose and then have them come back in a week later and get the other half dose. So that's kind of off-label, but we've done that in a number of cases. I don't know that I would do that with RSV or COVID, but I think a lot of times listening to why they're so afraid definitely helps. I mean, and you probably would convince probably a majority of them by exploring that with them, but there's going to be a few where they just, will listen, but have already made up their mind. So that person, I'd say, invest in some masks so that when you go out, you're protected and you don't bring something home to your family or your friends.
Do we have any idea how prevalent vaccine hesitancy is in the population? My guess would be around 10 or 15%.
I think it's been, the articles I've looked at go between 14 to 15%, but it varies between flu, RSVP, not so much, but COVID. There's a lot of concern with people not wanting to get COVID boosters. So the data that they quote is 14 to 15%, yes.
Well, thank you. I'm still waiting for those magic words, but I think it's just more talking with the patients. And
I think the anti-vaxxers are always a problem, and I think if you look at the surrounding counties, I think at some point I read some report that highest incidence of the anti-vaxxers were in Marin County, from all the counties around here. Yeah.
No, I think a lot of it's just, again, sitting down and talking to them and figuring out what it is that's holding them back, and then present the information and maybe, open it up to a follow-up phone call or a Zoom meeting a week or two later and say, did you think about this again? Are you more receptive to it now? You maybe try different things for different people. I know it's a challenge. It's a challenge.
Thank you, Diane.
Thank you.
Appreciate it.
Thank you.
Again.
All right, next we have the financials. Dr. Tom McDonough is going to present August.
Thank you. I'm going to present the August operational performance, final numbers. Average daily census for August was 147 on a budget of 163, so a variance of 17. On a year-to-date basis, we're at 154 on a budget of 165, or under by about 11. Discharges, 968, we're positive to budget by 59, and we're favorable on a year-to-date basis by 85 days. Our patient days underperformed budget by 514 days, with the main detractors to the performance being our telemetry and med-surg, which contributed the bulk of that under patient days. Outpatient observation, 370 on a budget of 408, so positive performance by 38 observation days, and on a year-to-date basis, we're positive by 41 observations. Average length of stay is both favorable for the month and the year-to-date. For the month, we finished at 4.93 on a budget of 5.57, and on a year-to-date basis through August, we are 5.33 on a budget of 555, or 22 basis points of positive performance. On the operating indicators, our case mix was 1.684 on a budget of 1,547, for about 14 basis points of outperformance. And on a year-to-date basis, we're outperforming by 9 basis points on our budgeted CMI, or case mix index. Deliveries were 149 on a budget of 120, outperforming by 24%. And then on a year-to-date basis, we are also 29 over at 274 versus a budget of 245. Surgical cases came in at 544, which was favorable to budget by 10%. And we're favorable on a year-to-date basis by 8%, or 79. Cath lab cases were 199 on a budget of 192, or a 3.6% outperformance, and we are even through August on a year-to-date basis. Non-emergency outpatient visits came in at 9,031, favorable to budget by 320, or 4%, and we're favorable on the year-to-date budget by 1,014, or 6%. Emergency room visits came in at 5,100, unfavorable to budget by 315, and we are unfavorable on a year-to-date basis by 2%, or 218. The detail on the surgical and cath lab indicators, I would say on the surgical cases, 4 of the 6 case types exceeded their budget, and you can see that that is the orthopedic, the cardiac, the vascular, and the endoscopy. The 2 underperforming were neurosurgical cases and other surgical cases. On the cath lab, 50% of the case types were positive, with cardiac leading the way, 35 over budget, and neuro IR at 4. While we had peripheral vascular and non-vascular underperforming budget, both by 16. On the productivity, total FTEs were 1,640 on a budget of 1,706. So we're positive there by 66.1. And the FTEs per adjusted occupied bed, so this is a productivity measure and a cost measure, came in at 6.34, or over budget by 31 basis points. And on a year-to-date basis, we are slightly over budget by 3 basis points, 6.14 versus 6.11. On the revenue side, actual revenue came in at $221 million on a budget of $212, 8.7 outperformance, or 4.1%. On a year-to-date basis, we are outperforming 4.8% on our gross revenue. Taking us down to the bottom of the slide, total deductions based on contractual and provision for bad debt came in at 77.53 on a budget of 77.01, or slight underperformance. On a year-to-date basis, our total deduction is at 77.02 on a budget of 77.05, so out on the year-to-date. Moving forward to the GASB financial statement, I'll take us to row 3. The net operating revenue for the month came in at $50.7 million on a budget of $50.2 million, so outperformance by just over $500,000. Operating expenses came in at $49.9 on a budget of $50.5, so again, outperformance by just over $500,000. Bringing our net operating income to $770 million on a budget of negative $770,000 on a budget of $319,000, so outperformance by $1.09 million. On a year-to-date basis, we are sitting at $73,000 positive through August on NOI on a budget of negative $446,000. So again, outperformance by $500,000. Moving us down to the bottom, our non-op income section came in positive at $2.6 million on a budget of $617,000 for the month, and on the year-to-date, we're at $4.98 on a budget of $986,000. So outperformance by basically $4 million. So summing up the net operating income and the non-op income, we finished the month at $3.4 million on a budget of $300,000. And on a year-to-date basis, we came in at $5.1 million on a budget of $540,000, for $4.5 million outperformance. Next, we move to the FASB. So the GASB, G-A-S-B, is the Government Accounting Standards Board. And now we look at the Federal Accounting Standards Board, which is what the private hospitals and other healthcare organizations that are non-governmental use. And the difference here being the GASB recognizes revenue when it's available to spend and expenses when they are due, while FASB measures performance based on economic events and with little regard to the time and date of the cash flow. So as we look at that, we can still see on the 5th line down, net operating income is positive at $224 on a budget of negative $936,000, so a positive $1.2 million. On a year-to-date basis, we are negative under FASB at $861,000, but it's on a budget of $1.7 million, so we're positive on net operating income. And then down at the bottom, our net income is positive $954,000 on a budget of negative $43,000 for the month. And then on the year-to-date basis, we sit at $861,000 on a budget of negative $141,000. We move on to EBITDA, earnings before interest, depreciation, and amortization. So we're the 5th line down. We're at $4.3 million on a budget of $3.2 million. So outperformance by $1.1 million for the month. And on a year-to-date basis, we sit at $6.9 million on EBITDA on a budget of $6.5 million. So about $400,000 of outperformance. And with that, August is completed. Any questions?
I was wondering why the property tax revenue was so far ahead of budget. 840, I think, was up.
Yeah, so it's a timing thing with the county providing us. That's the money that we use to pay the GO. So we kind of get it, pay it over. They have to have it paid to us by a certain date. It doesn't not fixed.
So to the extent it's over now, you think it'll be less?
It will normalize as we move forward.
No.
Any other questions?
No.
All right, I'm going to move on to the preliminary operations report for September. And I just want to say that I think we're aware that September just closed as of last week. And so it's been a challenge for us in terms of getting everything, all the numbers together. And I want to say they're very preliminary. As you are probably aware, we have the UCSF ortho physicians here that are doing many new cases and that we have not necessarily done through trauma, along with using new equipment and supplies. And so we do have a backlog of getting these cases and the charges into our system. So these are preliminary. We'll see them when Tom presents the actual final numbers next month. I think you'll see that our revenue is going to be much closer to budget than what I'm going to be showing tonight. So I do want to just say I feel conservative and very preliminary right now. So to start with, in terms of our total gross revenue, patients' gross revenue came in at $198.9 million for September, which was unfavorable to the budget of $216.1 million by $17.2 million or 7.9%, but was higher than the September of 2023 by $8.2 million or 4.3%. And then year-to-date, revenue was favorable to the budget by $2.9 million or 0.5%, and favorable to last year-to-date by 10.6%. Moving on to our trauma cases, this month we saw 147 cases in September, which was favorable to the budget of 105 by 42 or 40%. And then year-to-date cases were favorable to the budget by 97 or 31.4%. Again, inpatient trauma cases of 53 for September was unfavorable to the budget of 65 by 18.5% or 12. And outpatient trauma cases of 94 for September was favorable to the budget of 40 by 54 or 135%. So again, as I've kind of talked about, we're seeing a lot more outpatient trauma than what we had budgeted in terms of inpatient. Moving on to the trauma cases by activation code, as I've mentioned in the past, there are 3: Alpha, Bravo, Delta. Alpha is the most acute type of cases, followed by Bravo and Delta. So again, there were 147 cases, 27 of them were Alpha. And for this month, there 10 were Alpha, 38 were Bravo, and 99 were Delta. And you can see on the far right, in terms of year-to-date, and there are 27 Alpha, 137 Bravo, and 242 Delta. Also in September, out of the 147 trauma cases, 46 were falls, 21 were motor vehicle crashes, 5 were head injuries, and then 75 were classified as others. So seeing a number of falls. Moving on to the gross revenue for the trauma. It came in at $12.8 million for September, which was unfavorable to the budget of $13.3 million by $485,000 or 3.6%. Year-to-date, we are favorable to the budget of $1.1 million or by 2.7%. So again, I think we'll see some of that gap in between budget and what we're seeing close as we get all the charges in. Inpatient gross revenue for trauma came in at $8.5 million and was unfavorable to the budget by 27%, and outpatient trauma gross revenue of $4.3 million for September was favorable to the budget by $2.7 million or 105%. Moving back up to the total inpatient gross revenue, came in at $112.8 million, which was unfavorable to the budget by $12.9 million or 10.3%, but was 7.1% higher than September of 2023. And again, I feel the gap is closed. Then moving on to outpatient gross revenue, it came in at $86.1 million. It was unfavorable to the budget by $4.3 million, or 4.7%, but was just $725,000 or 0.8% higher than September of 2023. Average length of stay. Our average length of stay came in at 4.99, which is favorable to the budget of 5.23 by 2.4 or 4.6%, and the average length of stay was lower than September of 2023, which came in at 5.09, so by 2%. A couple of things driving that. Length of stay for trauma came in at 4. And so again, our length of stay for our trauma patients are lower than what we had expected. Also, excluding trauma, the length of stay was 5.05. Also, less patients we have seen less patients with stays more than 30 days in fiscal year 25 compared to fiscal year 24. So that has also helped a lot in terms of the work that we've been doing around transitioning appropriately to that next level of care. In terms of moving on to our average daily census, inpatient daily census came in at 150.4, which was unfavorable to the budget of 173.4 by 23 or 13.3%, but was higher than September of 2023 average daily census of 145.5 by 4.9 equivalent days. Again, I think this is driven by a number of points in terms of less inpatient trauma, but again, also really working in terms of transitioning patients to that right level of care. Discharges, September discharges came in at 886, which was unfavorable to the budget of 994 by 108 or 10.9%, but was 8.4% more than September of 2023. Again, during this time, we did not have any patients that were discharged that had to stay over 30 days. So if you remember, if anybody stays more than 30 days, all those discharges, well, you'll see that in the patient days, are attributed to that month. So you can see in our patient days on our next slide, we came in at 4,581 that were unfavorable to the budget of 5,203 by 622 days, or 12%, but were 5% more than September of 2023. Our ICU days were favorable to the budget by 11.9%. Our IMC, the three areas that were below budget, IMC, was unfavorable to the budget by 9.7%. Telemetry days were unfavorable to the budget by 16.9%, and med-surg were unfavorable to the budget by 15.7%. So those are the areas that we're seeing. In terms of our surgical trend, total surgeries in September of 479 were unfavorable to the budget of 537 by 58 or 10.8%, but were 9.4% more than September of 2023. Our inpatient surgeries came in at 206. They were unfavorable to the budget by 54, and outpatient surgeries of 273 were unfavorable to the budget by just 4 or 1.4%. You can see in terms of our surgical activity, we were down in all areas except endoscopy. We did have a couple of physicians that were out of town, but we also, as I said, came under budget in all, especially in other surgery, and some of that had to do with the number of surgical cases, trauma and general surgical cases that we did not do. Looking at our cath lab trend, the cases for September came in at 183. They were unfavorable to the budget by 16 or 8, but were 10.9% more than September of 2023. Again, we've continued to see strong volumes in our cath lab over the last number of months. And so cath lab inpatient came in at 97 for inpatient cases, was below budget by 14.2%. But outpatient cases of 86 was consistent with the budget. As you can see with the breakdown, we continue to have strong cardiac cases in terms of cath lab activity. We were down in non-vascular IR and peripheral vascular cases, but was one over in neuro IR cases. I will say we do have a new new interventional radiologist that started this month. She joined Dr. Bruce Lin and Dr. Doshi, and so she started well and had performed 17 cases in terms of non-vascular. So I think she will be a good addition to our IR team there. Looking at deliveries, deliveries for September came in at 141, and they were favorable to the budget by 3.7%, that were one fewer than September of 2023. Year to date, we are favorable to the budget by 34 or 8.9%, and also favorable to last year. In terms of non-emergency outpatient trends, we were unfavorable to the budget by 6.2%, but more than September of 2023. There are two areas that we were below budget, and that was in cardiac rehab visits. We are recruiting for another cardiac rehab nurse, and then also lab visits were down, and that was very much driven by surgical volume being down too. Looking at our emergency department visits, they came in at 4,872. They were unfavorable to the budget by 10.7%, but again, we're 2.1% or 100 more than the prior year. And year-to-date visits were unfavorable to the budget by 802 or 5%. We were seeing more, we've seen less in terms of sort of those basic and intermediate level cases, and seeing more of the level 4, 5, and 6 in terms of what the types we're seeing. Looking at our gross revenue recap, again, these numbers will be changing in the final numbers. As I mentioned, just to call out surgical services, cases were down 10.8%, but our gross revenue, as you can see, is down 31%. I think you'll see we're going to be much closer to budget in terms of once we are finished getting some of the charges in for those surgical cases. It's also impacting ancillary numbers, and you can see that they're off by 4.6%. Our room and board is down 3.2% due to less in terms of our inpatient stays. We did see favorable in terms of our cath lab services. It's over by 8.1%. That's really due to the types of cases that we were still, even though our cases were down 8% in terms of by 16. So, and also emergency department revenue was up by 12.2%, again, due to the types of cases that we're seeing. Looking at our preliminary payer mix, total government payer mix came in favorable to budget at 73.1% compared to a budget of 74.5%. HMO came in at 3%, which was favorable to the budget of 1.7%. PPO came in at 20.3%. That was unfavorable to the budget of 21%. VA TRICARE came in right on budget, and private pay we see tick up a little bit at 2.8%, so unfavorable to the budget of 2%. But again, as we've talked about, some of these trauma cases are classified as private pay as we work through the payer with the patients. Moving on to productivity indicators for our productive FTEs, adjusting for volume. Our productive FTEs for September came in at 39.7 or 2.7% favorable to the flex budget. Moving on to our non-productive FTEs, also came in they were pretty much right on budget. It was unfavorable by 0.1, that came in at 202.7 versus 202.6. So pretty close to budget for non-productive FTEs. Then looking at our total FTEs for September, they came in at 39.6 or 2.4% favorable to the flex budget. In terms of looking at our total FTEs for adjusted occupied bed, they did come in at 6.08, which was unfavorable to the budget of 5.90 by about 3.1%. Moving on to Radiation Oncology Center, looking at our treatments, they did come under budget. They came in at 270. They came in 90 treatments under budget. And the budget was 360. As we've talked about, really needing not only to look at treatments, but then if you turn to the next page, looking at our consults and also the new patient seen. So in September, you can see we received 36 new referrals that came in. That's the blue line from various sources. And then in our clinic, we did see 26 new cases. At this point, the conversion rate is 25%, so there are 9 patients that are now being seen as patients in radiation oncology, but there are also 22 that are still pending in terms of their still getting additional treatments or consults are being scheduled in October. So we continue to see new referrals and clinic visits coming in. So it just takes time to translate to actual patients that are being treated in radiation oncology. Moving on to Washington Township Medical Foundation. Visits came in at 15,632. They were unfavorable to the budget by 212 or 1.3%, but higher by 3.8% than September of 2023. In terms of looking at some of the areas, we were above budget in our women's health clinic and also our vascular clinic. That was offset by being unfavorable to budget, and contributing to that was pediatrics. That was one of the areas we are having some challenges with recruitment of providers, and so that was a challenge. And then also we'll also have other PCTs that are coming in that we should be seeing in the next few months too. Moving on to the Development Corporation, DevCo outpatient visits came in at 2,062. They were unfavorable to the budget by 104 or 4.8%, but 9.8% more than the prior year. That was driven mainly by two areas. Washington Outpatient Rehab Center was under budget by 3.5%. WASC, Washington Outpatient Surgery Center, was under by 9%. We had two of our physicians that had days off during that month, and so that contributed to that, basically that 9% that was below budget. And PSC, or other surgery, was just right on budget. Looking at our financial statistics, you can see our days cash on hand for September ended at 132 days, an increase of 4 days from the prior month. We had less outstanding checks this month, decreased by $4.7 million. We also really have been, our revenue and cycle team has really been working hard, and they've hit some really strong goals, and we've seen our operating cash increase $2.5 million or 8% increase versus the prior month. So that has been very strong, and a lot of great work that's been happening over in revenue cycle. Looking at our charity care, there was $261,000 in charity care adjustments for September, and we're continuing to follow up on those cases. Lastly, I just want to touch base on our unhoused patients for the quarter. As you can see, for the last 3 months, from July through September, there were 524 patient encounters representing 316 unique unhoused patients. Of the 316 unhoused patients, 79 had multiple encounters in the hospital. The total unreimbursed costs for this period of time came in at $2.3 million. Those are the preliminary statistics for September. Any questions?
Since certain months you have the second Wednesday coming before the 10th,
right,
when it becomes very difficult to do the previous month. Is there any reason why we can't have the hospital report on the third Mondays? So by then, you'll get much better handle of.
Well, I think that we've usually done it during this meeting, because this is the meeting that we had of our time was sort of, for all of the different reports and everything. I am happy we can give an update on sort of where things stand, and just a preliminary update. I'm happy to do that at one of our other meetings.
I was just asking because I thought it would be much easier for you people. So, you'll have more time to,
Yeah, I mean, as I said, I can talk with Tom as to what makes the most sense, but I think whatever that we can look at doing.
If we have all the systems, so we could actually get it
done. Yes. So
faster, better, easier.
Yeah. But we can always, why don't I talk with Tom, and we can figure out what makes the most sense on some of these months that it is challenging, because I know the finance team does have a lot to do within that short period of time, and absolutely, you're right, it's hard because they basically just have a few days by the end of that Friday to get it all put together, so.
Nevertheless, this time around, it was out of your control.
Right, but again, as Dr. Nicholson said, I think we're working hard to put those processes in place, which is absolutely true. I know that we've got revenue cycle, we've got the OR teams, and we've got supply chain that are all working, because there are a lot of different departments that touch this. And so I think at the end of this, we will have processes in place so that we won't have as many challenges. I'm not going to say we never will have challenges. We won't have as many challenges as we have now. So.
And with all the AI coming in, maybe you should be able to do it by first of the month.
Yeah.
But what we're aiming for is real-time financials.
Yes. Yes, and that's cleaning this up now and identifying this as we implement the ERP and the connection with Epic.
Mm-hmm.
Yeah.
Right.
Yeah. So we'll work to come back.
Okay. Calendars.
All right, moving on in terms of, I want to start with the Employee of the Month for October of 2024, and that's Roy Coloma, one of our great RNs, and I want to talk to you a little bit about him. 16 years ago, Roy graduated from the Dominican University in San Rafael and joined the new grad program at Washington Hospital. He began working on 6 West in the Med-Surg department. Over the years, his professional development has included becoming a staff nurse 2, board-certified medical surgical nurse. In 2015, he joined the treatment services as a PIC nurse, obtaining his vascular access board certification and staff nurse 3. Members of the PIC team may be called to assist in any area throughout the hospital, including the emergency department. Roy's calm demeanor and expertise make him the go-to person when an insertion is challenging. He enjoys meeting coworkers and patients throughout our campus and describes his job as never a dull moment. Roy is an excellent example of determination and hard work, leading to many opportunities within nursing. In addition to developing his knowledge and expertise through board certifications, he has taken on leadership roles. Roy is the co-chair for the Nursing Quality and Research Council and is part of the Central Line Associated Bloodstream Infection Work Group. Roy has been involved in various projects and initiatives related to the standardization of care and maintenance of central lines, assisting with zero CLAPSIs for more than 866 days. I think that's changed by, probably more by now. But yes, that team has been very instrumental in us not having a CLAPSI for quite some time. And he was featured in our most recent annual report. Utilizing his expertise and knowledge related to vascular access and his leadership skills, Roy trains new hires and new members of the PIC team on vascular access. When it comes to the patient-first ethic, Roy and other PIC team members know that each patient is unique and needs to be treated as individuals. Patient safety is their top priority. And congratulations to Roy on becoming our October Employee of the Month. All right, I'm going to move on to our health promotion and community outreach events. And we've had a busy month for September and October, so I'm just going to kind of pick out some of the highlights of those. As you can see, on September 13th, we participated in Senator Aisha Wahab's Emergency Preparedness Fair at the Newark Police Department, and had 50 community interactions. Also, our trauma team on September 17th did Stop the Bleeding training in Washington West and trained 23 nurses. And then also on September 18th, Larry Aseo, our physical therapist, did a wonderful education on falls prevention at District 3. September 20th, you can see we were at the Union City Family Center Toddler to Career Fair, and we did 33 blood pressure checks. We also participated on September 21st and 22nd at the Newark Days Parade and Community Resource Fair, and again did 65 blood pressure checks were taken there. The end of the month, at September 25th, Dr. Shariat Our co-medical director and intensivist did a talk on sepsis, what it is, and how we can increase awareness, and we had 766 views on Facebook, YouTube. As you can see, our trauma team has been very busy, again, out in the community. On September 26th, Dr. Chet Morrison, our medical director, spoke at the Cal State East Bay Trauma Symposium, which about 75 people attended. I know you heard about Mutstrut and participation there at Masonic Home. On September 28th, we also participated in the HERS Run Walk Yoga at Quarry Lakes, and there were 250 people that attended that event. Moving on, in terms of into October, you can see that our, again, trauma team was at Science in the Park and trained 85 people on Stop the Bleed. Also on September 7th, we were at Newark Unified School District Child Nutrition Day in service. And, excuse me, we trained 28 teachers and people part of the Unified School District in Stop the Bleeding and Choking First Aid. And also, Emily Gentry talked about breast cancer surgery on Facebook Live and YouTube today and had 133 views. So there are a few pictures, to go through those. All right, I'll just highlight a couple of upcoming events. I think we've heard that this Saturday is our 38th annual Top Hat Gala. That's going to be benefiting MRI services. So we're very much looking forward to that. Then on October 17th, we're hosting the 16th annual Think Pink breast cancer awareness event. Also will be in our Washington West tent. So encouraging everybody to come to that. You can see also our trauma team is going to be out there doing some more education. Following that, again, Dr. Morrison is going to be also presenting at the 35th Annual Totally Trauma Conference in Monterey. Also just want to point out on October 23rd, Dr. Stella Asuko, our vascular surgeon, is going to be talking on Facebook Live and YouTube, treating carotid and aortic disease through endovascular innervation. So that, moving on to some others that you can see that are happening. We will be at Newark Dia de los Muertos in Newark with an education booth. Also participating on October 27th with a booth at the Abrune Foundation Walkathon at Quarry Lakes. And also just want to mention on October 29th, Dr. Seigel, our spine and neurosurgeon, is going to be talking about low back pain for seniors at Acacia Creek. So those are some of the upcoming events. As mentioned, also, you know, we do have the Top Hat, but also want to mention and put it on everybody's calendar, December 5th. We will be holding our annual tree lighting, holiday tree lighting at 5 p.m. in Washington West. So that is our calendar, busy September and October.
Come on. Already talked about Christmas.
And then December.
Thank you, Kimberly. And we'll got two action items mentioned by
Mr. President, I move the Board of Directors authorize the Chief Executive Officer to proceed with awarding the contract to James R. Griffin and amend the budget for the MRI mobile trailer construction project by $101,645 for a revised budget amount of $601,645.
As you know, yes, we're putting in the mobile MRI that's going to be the left of the emergency room. And what's really happened is, in terms of the main driver of this cost increase, was the electrical scope, that we found out that in terms of needing and the complexity of wiring the MRI into the more time and critical care pavilion. So, well, it is going to be delivered in the middle of November, so we are moving forward as quickly as possible. So we hope to have it up and running by the beginning in December. So, yep, we're on a tight time frame.
I'm going to take a roll call. Director Eapen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Okay, action item.
Yes, Mr. President, I move that the Board of Directors approve the appointment of Carol Dutra Vernacci to fill the vacant position on the Washington Township Hospital Development Corporation Board of Directors for the remainder of the 2024 calendar year.
I'll second that.
As you know, Dr. Bensaw has retired after many, many years on the Development Corporation Board, and very excited that Carol is putting her hat in the ring. Many of you know her. She's going to be ending her time as Union City Mayor. She made history in December of 2012 when she was sworn in as the first woman mayor in Union City. She is a third-generation Union City resident, growing up in Dakota and now living in Alvarado. She's a graduate of James Logan High School, class of 1972, and alumna of California State University, Hayward, with a degree in psychology and taxation education. And she's held many roles in several nonprofits throughout the community. So.
Okay, roll please.
Wonderful person.
Yep.
Director Eapen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? Director Stewart?
All right.
Any announcement?
Nope, no.
All right. Well, that being no further business, the meeting is adjourned.